Second. I'm so proud of our volunteers and what we did. Life Senior Services does taxes for people 60 and over with incomes of 60,000 or less. So it's a moderate to moderately low income. And we did 1,831 tax returns this year. So for one facility to do that many in one location is great. I had 30 different volunteers that helped with that program. So I was very thankful for each and everything that they did. So next year, if you fall under those guidelines, please come see us. We'll do your taxes for free. So to Medicare now. So most of you know what Medicare is. It's for people, a federal health insurance program for people that are 65 and older, people under 65 that are on disability and have been on disability for over 24 months. It's for people that have been taking out Social Security. They're automatically enrolled, and for individuals with ALS and those type of things, and stage renal disease. It is administered by the Centers for Medicare and Medicaid Services, which is also known as CMS. And you sign up either through Social Security, SSA.gov, or you sign up through railroad retirement benefits if you're a railroad retire employee. So Medicare enrollment, some people are automatically enrolled that are receiving, like I said, Social Security benefits or railroad retirement benefits, 62 to 65, and those for disability. So if you're not automatically enrolled, you should sign up during your initial enrollment period, which is a 7-month window. It's 3 months before your birth month, and then 3 months after. Now, there's some circumstances, and we'll talk about those, where you can delay signing up. So, and if you have questions, stop me at any time. It's not a problem. Yes, sir.
What about on your program? Mm-hmm. The teacher's retirement?
Teacher's retirement is separate. So retiree benefits from places that have those type of benefits are usually much better than what Medicare offers. Sometimes they can be a little bit more.
But I'm saying the conflict, you can't do one from each?
No.
Okay.
No, you have to have all of
all
one.
Or one.
Mm-hmm. Mm-hmm. Absolutely. So if you have an employer group plan, you can wait to sign up for Medicare until you get ready to retire, and there's no penalties. Yes, sir.
Okay, so if what that slide is telling me, because I'm still working and intend to for a number more years, but I'll turn 65 in July. So I do not have to sign up for Medicare at 65.
You do not
do anything stating that you're not signing up?
No, you'll do that when you sign up. So if you delay it and you go to sign up later when you get ready to retire, CM or Medicare will ask you to fill out a special form, which is the CMS L56 form, and I think it's in here, stating that you had other insurance, when that other insurance was effective from the date that was eligible, you were eligible to your retirement date, and you will send that or attach that document to when you enroll.
Okay.
I had heard there's a penalty if you don't sign up by 65.
There's not. It depends on the circumstances. If you're like this gentleman and you're still working, then there's no penalty, and that's why they ask you to fill out that additional form, just to show that you had active group, coverage, and there's a reason you're delaying that.
Is there a period of time that they say you needed that active group coverage? I thought on one of this that you had to have done like 40 something like, and maybe you're going to get to it on the next slide.
Yeah, that has to do with the premiums.
Oh, okay, good.
Yeah, and I'll get to that in a minute.
So it's not just if you're working, but you have to have insurance coverage while you're working.
Correct.
Is that right? Okay.
Correct. That is correct.
So, you could be working but not have insurance, and in that case, then it would throw a wrinkle.
Yeah, so if you're
Like-
working and you don't have employer group coverage, then you need to go ahead and sign up for Medicare during that 7-month open enrollment window. Okay,
Okay.
all right.
One more,
Um,
as far as-
yes.
What about self-employed?
Mhm,
I shut down my business,
Mhm.
so I don't have the corporation anymore,
mhm.
but I still occasionally take contracts. You know,
But those are 1099 contracts, right? So it's a
Varies.
1099? Okay,
sometimes I work for a company who wholesales me for
okay.
marketing, and sometimes it's direct, so it varies.
Okay, so do they offer you active employer coverage? Okay, then you would need to sign up. Yeah,
We are signing.
okay, all right. Okay, so this is a copy of a Medicare card. They used to use social security numbers, which was a bad thing. But they got away from that in 2015. And it's now just a random selection of numbers and letters. This card will also show you under Hospital Part A when that effective date was, and under Hospital Part B when that effective date was. Now, you can have A without B, and you can have different dates on A and B, okay? Just depending on when you sign up for the individual plans. So Medicare Part A is hospital premiums. Most people receive it free. If you have worked 10 years or 40 quarters, you're eligible for free Part A. Now, I say free, but it's not really free because you've been paying for it your whole life in FICA taxes. But you don't have an additional premium. Yes, sir.
So will they know, like, if, and that's the other question that I had, since this is free, not free, I paid for it for all those years,
Yeah.
but since it doesn't cost me anything now, for someone in this room that's working, that has their own insurance, wouldn't it be to my advantage to go ahead, because I've got more than the 40 credits, wouldn't it be to my advantage to go ahead and sign up for this, since I'm not paying for anything, and my primary insurance will still cover, and then it would fall to Medicare if
Secondary.
anything ran over?
It would follow as a secondary insurance company, and absolutely. It's your choice if you want to go ahead and sign up for Part A when you're 65. I would recommend that you do it, but you don't have to do it. But it is kind of a second coverage for you. And if it's free, why not? You know, you've paid for it, so why not get some of those benefits? If you haven't worked 10 years or 40 quarters, and you've only worked between 30 and 39 quarters, then it's $278 a month that you pay for that. If you've worked even less than that, it's $506 a month for that insurance. Yes, sir.
When you sign up for this, they will know if you've worked that many quarters.
Absolutely,
Okay.
absolutely. And it doesn't have to be consecutive either. You can have worked for 2 years, taken time off to raise your family, come back and work another 3 years, and then take a couple of years off, come back, work another 5, as long as you've got 10 accumulative lifetime years. Okay?
Thank you.
You bet. So Part A is basically your hospital insurance. It's inpatient hospital charges, inpatient skilled nursing. Some home health falls under Part A, hospice cares, and blood after the first 3 pints. Medicare wants you to cover the first 3 pints. They'll cover it after that. No rhyme or reason at all to that. So the Part A deductible is $1,600 this year, and that's per benefit period. So $1,600, and when I say benefit period, if you go in January and you come out in a few days and you have to go back in February, you don't have to pay that deductible again. But if you go along and you go back in April 1st, then you have to pay that $1,600 all over again. So there can be multiple times where you have to pay that $1,600 if you have to go into the hospital frequently. Now, it's inpatient. So if you go to the emergency room and they put you under observation, that's not inpatient. So that would be covered under your Part B benefit. Okay, yes, sir.
The blood. Does that have to be consecutive? Or is that, you know,
That's per inpatient stay.
okay,
Yes. Okay. Now, if you are in the hospital beyond 60 days, which very rarely ever happens anymore, it used to happen quite a bit. But if you are in 61 through 90 days, you have an additional $400 per day you have to pay. If you're in between 91 days and 150, it's $800 during that period per day. Now, that 91 through 150 is a lifetime, one-time benefit that Medicare offers. So if something happens and you have to go in and you're in there 100 days, Medicare is only going to pay that additional period beyond that 91 days, that one time. If you have to do it again, it's on you. They'll pay for everything up to that, and then you pay for everything beyond that 91st day. Okay. So Medicare Part B is everything else, basically. It's your outpatient services. So outpatient surgery, emergency room, urgent care, doctor visits, lab work, diagnostic testing, durable medical equipment. So that's your wheelchairs, walkers, insulin pumps if you have an insulin pump. It's your nebulizers if you've got nebulizer that you use. It's all under that bracket. That is $164.90 a month. It went down from $170.10 last year, but it fluctuates a lot. The year before it was $148.50. So there's jumps that, you know, can happen in that. If your income as an individual is over 97,000, or if you have a joint return that's $194,000 above those two, then you'll pay an additional premium, and that's going to be $230.80. If your income is higher than that, then you pay more, according to that chart. Yes, sir.
So if you sign up for this, and let's say they're going to look at probably your last year's tax returns or your last year's income.
Last 2 years back.
All right, so 2 years back.
Mm-hmm.
So when you retire though, okay, so you would pay a higher premium here, but after how many years would you have to work? Let's say that I'm making considerably less money
Yes.
than I was. Is there a way that you can go in and lower these premiums, and how do you do that?
Absolutely. Once you are able to show a tax return that equals less than that, you can request Medicare to lower your premium based on your new income.
Do you do all that online, or do you go like to the Social Security office to do that, or?
You can fill out a form and do it all, or you can do it online or fill out a form and send it to them.
Okay.
I don't suggest that you go to the Social Security office while it's open, and you can. It's usually 4 and 5 hour wait times.
Okay.
If you walk in. If you need to go to the Social Security, I highly recommend that you call them and make an appointment before you go in. Now, again, your wait time on the phone is going to be dramatically increased right now too. So it's usually an hour to 2 hours. So if you call them, make sure that you put them on speaker and you just do your whatever you need to do, because you're going to be holding a while.
So it's best to do it online if you can.
If you can.
Okay.
Absolutely. But a lot of the people that come to us don't have access to computers. Most of them don't even know how to get their voicemails off of their phones. So they're very technically challenged. So that's things that we can help with as well.
Thank you.
Yeah. Okay. So like I said, Medicare Part B coverage is basically anything other than inpatient, skilled nursing, hospital, home health, those type of things. What you're going to pay for services under Part B is a one-time annual $226 deductible. And then it's paid 80/20. You pay 20, Medicare pays 80. Now, when I say that, it's not 20% of the billed charges. It's 20% of the Medicare allowable. So you may go to the doctor and the doctor may say, well, I'm going to charge you $200 for coming in, and seeing you because you were here a whole 15 minutes. And then they send the bill to Medicare, and Medicare says, we're only gonna cover $80 based on your contractual rate. So it's 20% of that $80, okay? Okay, so with Medicare, you have, when you sign up, you have two basic options. You have original Medicare, which you can get a supplement to pay for those charges that Medicare doesn't cover. So maybe that $1,600 deductible or that 20% co-insurance, those type of things. And then you, they say, can add a prescription drug plan, but I highly suggest that when you sign up for Medicare, you go ahead and get that prescription D plan. Even if you don't take medications, just get your foot in the door and get the lowest premium that you can get, which is right now $7.10 a month. Because if you don't and you delay getting it, they're going to penalize you for not getting it when you could have originally had it. Okay. Or there's Medicare Advantage plans, which is really similar to what you have through a group health insurance. Usually those plans, you have to see a network of doctors, specialists, those type of things. They do include usually that prescription drug plan. So you want to be sure and get one that does have it. So supplements. So supplements are sold by private health insurance companies. They are sold, federal law allows, has things that, I can't even talk, sorry about that. Federal law, they put laws in place that protect you, sorry about that. They cover gaps in original Medicare. Like I said, maybe the $1,600 deductible, 20%, but none of them currently pay for that $226 annual Part B deductible that they sell currently. There are plans A, B, C, D, F, G, K, L, M, and N. That's a lot. Plans C and F are no longer available to people that are Medicare eligible after 1/1 of 2020. If you were Medicare eligible before then you can still purchase those plans. The difference basically in those plans, rather than the other ones, is that they do cover that annual Part B deductible. But when you look at premiums, you're better off paying $226. Okay, the same layer plans have the same basic benefits. Plan G has a high deductible plan, which is almost $2,500. So you can purchase one of those plans at a relative low monthly premium, but you do have to pay the first, I think it's $2,500 out of pocket before they pay anything. Plan C and F are no longer effective. Here's just a rundown of what the different plans are. So if you'll notice, Plan A, Plan A only covers co-insurance and hospital costs at 100%. They cover Part B co-pays or co-insurances at 100%. They cover those first 3 pints of blood, and they cover Part A hospice. They don't have skilled nursing facility benefits. They don't have the Part A deductible. They don't cover the Part B deductible, and they don't cover Part B excess charges. Let me talk to you about excess charges. So Medicare has 2 fee schedules that doctors and facilities can sign up with. Basically, one says, I'll take your allowable and we'll write off the balance. No problem. The second one is they say, I don't like your fee schedule, so I want to charge 15% more. And Medicare allows that. So it depends on what contract they have as to how that doctor's charges are paid. So some of these plans, like G, for instance, looks like is the only one that covers the excess charges for this year. That plan will cover those at 100%. So if you get a bill and the doctor says, well, this is that 15%, then your supplement will pick that up. Okay, so depending on what plan you choose is what plan that you get the benefits from. And G has the most benefits at this time. N is really close and D is really close. D actually, yeah, is really close. So those are your best three. Now those plans are going to have your most premium, highest premium as well. So those can be between $90 and about $150 starting out, depending on what you choose, your age, if you're a tobacco user, those type of things. Okay, so Medigap open enrollment period. There is a one-time 6-month open enrollment period that they can't charge you more based on any previous illnesses or your age. And that is a 6-month window when you sign up for Part B, not A, just B. So if you wait and you retire at age, let's just say 72, and you sign up at that time for Part B, you've got that 6-month window starting for your Part B effective date. If you sign up at 65, that's when your 6-month window would be. Yes, sir.
If I wait until, let's just say 72 to retire, you mentioned earlier about Part D, that if you didn't get it, if you didn't sign up for it earlier, that they will penalize you for you signing up for it later. That's not.
No,
Okay.
because you've got employer coverage, so that has no effect on a penalty right there. Yeah.
Thank you.
But if you say go 2 years down the road, you go ahead and get Medicare, and you don't sign up with a supplement plan, and you wait 2 years. That 2-year window, they can ask you a whole lot of medical questions. And if there's anything that excludes you from purchasing their plan on those medical conditions, they can say, sorry, I'm not writing you a policy. Or they can say, okay, I'll write you a policy, but it's gonna cost you $320. And those are just figures I'm throwing out there. Okay, so it's really important if you go the original Medicare route that you go ahead and get that supplement within that 6-month window. Medicare Part C, which is the Advantage plan. They are coordinated plans that are available to all people with Medicare. You still have that Medicare Part B premium, whatever it be, the $164.90 or above. And you still get the basic benefits of that insurance, of Medicare Part A and Part B. Medicare pays a set amount to those plans to administer the benefits. So some of these plans have a 0 premium. So you think, how can they afford to pay my claims if they're not getting any money? Medicare pays them to do it. Medicare Advantage plans may lower your healthcare costs and may provide benefits above and beyond those offered by Medicare. And when I say above and beyond, Medicare doesn't cover vision, dental, hearing, those type of things. Medicare Advantage plans do. They also can cover transportation. Or if you're in the hospital and you're a single person, you come home and you're not able to cook for yourself, some of those plans have meal plans that they deliver meals to your home. So those are yes, ma'am.
This is kind of waiting for you to get to this.
Yes, ma'am.
We are over 75, and I'm speaking for ourselves, and we've been on an Advantage plan for several years. However, we run into some circumstances with a friend where that Advantage plan is not an advantage. At what stage in our life do we need to be considering letting the Advantage plans go and go back to regular Medicare?
Before you have any serious health conditions.
Okay. So, and that would be, then carefully looking at all of the supplemental coverages.
Yeah, and who knows? I mean, and my husband had a heart attack at 56. So who knows what's going to happen tomorrow? Nobody knows. You may walk outside and get in your car and drive down the street and be in a terrible wreck or something. So it just, yeah.
Our friend, had a stroke,
Yeah.
and she was fine up until the day she had the problem.
Mm-hmm.
But the other dimension to this, which these Medicare Part Cs are really what they call managed care.
Yes.
And you may not get the amount of care that you need, and you may have to go through a long legal arbitration process to get that care.
We're just talking about you that are a little older. She ran into a problem of where she was actually being discharged from skilled nursing before she was ready to be.
With a
And
doctor.
that's where we learned about that. So we were able, we just happened to be in the time frame where we could disenroll her from the Advantage plan and enroll her in regular Medicare. So it's just something we were not aware of, and it turned out to be very important.
Yeah, some people it works great for their whole life, and some people not so much. So it just depends on your individual needs and wants and circumstances. Yeah, I don't say one way is, better than the other, because number one, I can't. We are given grant money by the Oklahoma Insurance Department to stay absolutely unbiased on everything. We are here to just educate and give you the information, and then you have to make the decision what's best. Absolutely. So let's see. And most plans cover the prescription piece of it as well. So you can join a plan or change plans during certain times if you enroll in a Medicare Advantage plan. Once you enroll in a Medicare Advantage plan, your benefits come only from that plan. You go to the hospital, you show them that card. You go to the pharmacy, you show them that card. You may need to get an authorization for certain services, or you may have to see doctors, certain doctors. Now, HMOs are the ones that have the networks that you have to use their doctors and you can't deviate. If you're on a PPO, then you have the option of using their physicians and facilities, or you can go out of network and use who you want. Now, you will still have certain authorization criteria that fall into place. So if you have to have surgery, they'll still have to approve it, those type of things before you get it done. But that does give you benefit to go out of network if you need to. Let's see, you pay a monthly premium. You still have the Medicare Part B premium that you have to pay. And your copays, deductibles, insurances may vary and be different from original Medicare. Okay, Medicare Part D. Is prescription drug coverage available to all people with Medicare, provided by Medicare-approved private insurance companies? Plans vary in cost and specific drugs covered. Again, it says enrollment is voluntary, but you need to really consider going ahead and signing up for a plan when you become Medicare eligible. Some people receive their prescription drugs through the VA, Indian Health Service, or if they're a federal employee, through their federal employee plan, TRICARE, and don't have to enroll in Part D. But understand, if something happens and one of those entities doesn't cover a medication for you, and you go to sign up for it later, Part D later, you're going to be penalized for all those months that you didn't have it. Yes.
One other thing, I use the Indian Health Service
Yes.
for mine, but I've also got Medicare as a backstop
Yes.
for those cases like you're talking about where IHS doesn't carry that drug, and I can go through Medicare for the regular drug.
Absolutely, absolutely. Okay, Medicare Part D options is through, you can get it through Medicare Advantage plans, through a separate prescription drug plan, which is also known as a PDP. And it's mainly intended, PDPs are mainly intended for people with original Medicare who have no other drug coverage. There's 24 different plans in Oklahoma in 2023, and those premiums are between $7.10 to $105. Now, there's such a gap in the two because usually the ones that have $105 premium don't have a deductible, and they cover a lot more medications than the lower premium cost ones do, and the lower premiums do have deductibles. So they have annual deductibles anywhere from $100 to $505 a month, a year. I'm so sorry.
One other point,
Yes.
and that's it. On the Part D, the thing you have to get into is the contrast between the formularies.
Yes.
The Medicare Advantage people sometimes have real expensive bumps for a Schedule III drug that,
The tier 3?
Yeah.
Yeah, and that's true even with regular Part D plans. Yeah, they have tremendous,
variance in
maybe
what
some
they
of them
cover.
are covered at zero and maybe some of them have a 50% coinsurance. And if that medication's $1,000, you're out $500.
And it's not unusual these days for some of those Schedule 3s to be over $1,000.
No, absolutely, absolutely. So if you know of somebody that has incomes as an individual that are $1,823 or less and resources of only $15,160, now resources do not include your home, do not include your cars. It includes IRAs, what you have in checking account, those type of things. Or if you're married with a income of $2465 or less a month and resources up to $30,240. I have an extra zero on mine. Then I know, right? Then you can get help paying your premiums, paying your deductibles, paying your co-pays, and that type of stuff. So benefits for extra help, you have reduced or no monthly premium, you have reduced or no annual deductible, you have reduced prescription drug costs with co-pays. In 2023, those co-pays for generics can be $1.45 or up to $4.15 for generics. For name brands, it's $4.30 or $10.35, and that's per fill. There's no coverage gap, and it gives you a special enrollment period, allowing you to make a change every quarter if you want to change your drug plans. Okay, so Medicare enrollment periods. So Medicare enrollment, you're automatically enrolled if you're getting Social Security or rural retirement benefits or disability benefits. When they send you a packet, you can say, sorry, I don't want it right now, and you follow the instructions on the letter and send it back to them. The initial enrollment period, again, when you're age 65, if you don't have other active employer group health coverage, you can sign up 3 months before your 65th birth month, your 65th birth month, and 3 months after. General enrollment period, if something happens and you say, I don't want to sign up right now, I'm not sick, I'm healthy, and you want to sign up later, the only time you can sign up later is if during a general enrollment period. And that's January 1st through March 31st every year. And the effective date, so if you sign up in January, it'd be effective February. If you sign up in March, it'd be effective April. Now, understand that if you sign up late without insurance, you're going to have to pay penalties when you sign up later. Medicare enrollment periods, if you're on a Medicare Advantage plan, you can change plans January 1st through March 31st. Medicare allows you to sign up or change plans during that time. You can go from a Medicare Advantage plan to another one, or you can go to original Medicare if you decide that's just not for you. You can join or drop a Medicare Advantage plan or Medicare drug plan during that time, and that change will take effect on January 1st. No, I dropped, sorry. The annual election period, I'm so sorry, October 15th through December 7th of every year. So that's when you need to look at your Medicare benefits. So it may be working great for you at the time, but you still need to check your prescription drug plans to make sure that that plan still is going to cover your pharmacies that you want. It's going to cover the medications that you want. If it's going to change the deductible for the year, the premium for the year, that's when they do those things, is January 1st.
Can I ask you another question?
Absolutely.
It's been several years now since I got into this, but there used to be an early enrollment period for people over 62 before they turned 65. Has that been eliminated now?
Yeah, the only time you can do that is now if you've been on disability for 24 months or more.
Okay, thank you.
Special enrollment periods, if you move, if you go from the hospital to home, if you go to a skilled nursing facility, Those all allow you special enrollment periods, so you can change plans at that time. If you lose other creditable coverage, like you retire, you can change. And that gives you an 8-month window. Okay? If you live or leave a long-term care facility, that allows you a special enrollment period. If you qualify for low-income subsidy, you can change every quarter. Please be very careful of what the phone calls that you answer, what information you give, and what you throw in the trash. Never, ever give anybody your Medicare number, Social Security, anything like that over the phone. Medicare and Social Security won't call you to get any information. They will send you a letter. If you get credit card applications, please shred those. Please do not put those in the trash. It's very important that you shred all of that material. You can report Medicare fraud by calling 1-800-MEDICARE. Okay, that's just a little bit of information about us. We can assist with enrollment, seminars. Sorry, I'm taking so much time.
It's okay, we had questions during instead of after.
You know, and that type of thing. So we can help with any of those things. Or if you have a question, please just call us. We helped 6,200 people last year. There's information on the Oklahoma Insurance Department also. So our service area is in Tulsa County, Creek counties, and Osage counties, but we help people in Missouri. We talk to people in Arkansas. Whoever calls us, we help. So, all right, that's it.
Thank you very much, Kathy.
Thank you.
What's the government website that you would go to sign up for them?
SSA.gov.
Okay.
Can we go ahead and pull that out?
All right.
That's okay. We ended up with questions in the end, so we're going to have a little less time than again. Okay,
Sit down until you figure out
who's going to go next?
Yeah.
You want to go next, or you want Jacob? Doesn't matter.
Let Jacob go.
Okay, we'll have okay. Yeah, one thing I have just started doing some stuff with my Medicare. You can go ahead and set up your own account with Social Security online, and then you can go in there to see how many quarters you have and all those kinds of things. So it's a good idea to do that.
Good try. It's really, there we go. It's in the lead.
I'll go ahead and finish it.
Thank you so much.
All right, our next speaker is Jacob Guinan. He is with the Alzheimer's Association. Jacob is Community Outreach Coordinator with the Alzheimer's Association of Oklahoma chapter in Tulsa and Eastern Oklahoma. He's originally from Altus, earned his bachelor's degree from Texas Tech. You won't forgive me for that. After college, Jacob joined the AmeriCorps Vista program. During his year of service, he worked with the Alzheimer's Association Montana chapter to expand their reach to veteran families affected by dementia and form a relationship between the association and the VA health system. In August of 2019, Jacob returned to his home state to continue working with the association. In his current role, he provides education on dementia to caregivers and the general public, conducts physician outreach, and works with other organizations to connect families with services. So welcome, Jacob.
Thank you, Martha. I never know what to do when people are reading your introduction. I guess you just stand here and
You
smile.
just stand there and smile.
Yeah. But thank you again, and thank you for having me here. I'm sorry I was a little bit late coming in. I thought I was early. I thought we were starting at 10, so but that's why I was late. But I appreciate you all having me here. We'll go ahead and get started with this topic, effective communication strategies for people who are living with Alzheimer's and dementia. It's a little bit different than the other topics we're talking about today, but I think it's really important. People ask me if you have to show someone one presentation from the Alzheimer's Association, which one would it be? And it would always be effective communication, because communication for people with Alzheimer's and dementia is just a little bit different than it is for everyone else. And there's no handbook that you're given by your doctor when you receive a diagnosis. So it's nice to have a little bit of a guide about what to do when you're talking with somebody who's living with this. So we'll go ahead and get started. In the next half hour or so, we're going to look at the communication changes that take place throughout the course of the disease. We're going to look at decoding the verbal and behavioral messages delivered by somebody with dementia and respond in ways that are helpful for that person. And we're going to look at strategies to connect and communicate at each stage of the disease. And I think first it's good to talk a little bit about communication and what it is. I think we've all heard before that, what we say is actually very little of how we communicate. A lot of our communication is our body language, our tone of voice, our facial expressions. And for people who are living with Alzheimer's, as they start to lose their words and they start to lose the ability to use language to communicate, they start to focus a lot more on all those other things, your body language, your facial expression, and your tone of voice especially. And so it's important to remember to really focus on those things when we're talking with people with Alzheimer's. This is a little bit of an overview of communication throughout the stages of Alzheimer's disease. You've probably seen other stages, other models for the stages of Alzheimer's disease. We use a 3-stage model. We talk about it in terms of early, middle, and late. So somebody with early stage Alzheimer's, they're still able to convey thoughts and feelings through words. They're still able to make decisions about future care, but we may start to see things, certain symptoms like memory lapses, especially short-term memory lapses, and they may start to misinterpret what others say and start to have a hard time following conversations. Once people progress into the moderate stage, we do see people start to use more basic words and sentences and speak less often. We also see people relying, like I said, more on tone of voice, facial expression, and body language for communication. And this is people do continue to need emotional connection and meaningful activity throughout this stage and throughout every stage of the disease. The research does show us that even somebody who is bedbound with Alzheimer's and maybe hasn't spoken in a long time, that person does still retain a sense of self throughout every stage of the disease. That person is still in there somewhere, so we still need to try to find ways to connect with them. In the late stage, this is when people, usually they lose the ability to speak for the most part. Maybe they'll still have some words and phrases they can use. And they might, not really be able to walk on their own. They might be wheelchair bound or bed bound or something like that. But they may still respond to familiar words, phrases, or songs. And we'll talk about music and other ways to connect with people when they're in this stage. And we can still use body language and the 5 senses to communicate. We'll talk a little bit about how we can use each of the 5 senses to communicate with people who are in that late stage when it's really hard to connect. And much like the previous presentation, if you have questions throughout, please don't hesitate to share them. I think it's always helpful. We'll start off by talking about communication in the early stage. Some of the changes that we notice when people are in the early stage is, we'll see people having a difficult time finding the right word. And one of the things to be cautious about when we're talking about this is sometimes when we're looking at these symptoms, we say, oh my God, that's me. I can never find my words when I want to. But it's important to remember that this is, it's a little bit of a different kind of forgetting. It's not just not being able to find your words occasionally. It's when it's happening a lot and when it's interfering with daily life. But we'll see people start to have difficulty finding the right words. We'll see people taking longer to speak and respond, and that is something that gets worse throughout the course of the disease. For people with Alzheimer's, their brains are working really inefficiently, and so everything just takes a little bit longer to do, and so we have to be a lot more patient when we're communicating or when we're asking them to do anything, really.
I just want to remark, sometimes there's a problem there. They may have a hearing issue also, and sometimes we can mistake that they're just not hearing.
Yeah, absolutely. And hearing is a big part of this too. And there's even some research that's showing us that hearing loss can be a warning sign, can be a risk factor for Alzheimer's. Because when you're not able to hear and your brain isn't getting those signals, then it starts to have problems in that way too. Yeah, absolutely. But then a lot of people have hearing loss and no dementia at all. And then, so you just have to look out for that too.
One other, you're talking about these stages like they're consistent.
Yeah.
And, like our friend, for example, sometimes actually sees things that aren't there, whatever, but then other times it's 100%.
Yeah.
So, how do you deal with the staging within these bands as you're...
Yeah, that's a really good observation, and that every day is different.
Right.
For some people, when we're talking about the stages, it's not like strict boxes that we're putting people in, because some people, they might have the symptoms that they're having may not be the same for the stage that they're in. Some days they might have symptoms of a middle stage or late stage where they're having a hard time talking, but then the next day they're totally fine. And so it's good to remember that we can't make assumptions about people's abilities day by day.
When you talk about withdrawing from conversations,
Mm-hmm.
my husband is, we've been in this home for 5 years now,
Mm-hmm.
but instead of withdrawing from conversations, he just chatters. Anybody walking down the hall, and he'll stop and say, "What's your name?" Or "I." And I don't know how to keep him quiet.
Yeah, and that's tough, and I don't know that you'll be able to.
Everybody knows.
We know. We love it, so it doesn't matter.
Yeah, exactly. But yeah, but most people don't mind, right? Because if they know that somebody's having a memory problem, and it's not like, well, sometimes they can be a little bit mean, but but even then, if you know that it's that this person is having a memory problem, it's okay if they, chatter. But it's right. Not everyone withdraws from social conversations. Some people get a lot more social than they were before too.
I can tell one way that he's getting worse is that he had his set little stories that he wanted to tell over and over again. And now he's getting them all mixed up, and he forgets what his own story was.
Yeah, and that's, so that's one of the things that can happen. But I always recommend that we just sit there and we listen at it anyway, because sometimes you can still, find out things that maybe you've never heard before, and maybe they're things that really happened and maybe they aren't, but it's, probably going to be a pretty good story either way. But we can just try to enjoy the time that we have and enjoy the fact that we're able to have a conversation with this person, I think, even though it is sad to see with the changes that are happening, and it can be frustrating too, because we're people and we've heard this story a million times before, but we just have to try our best to remember that for them it's the first time they're telling us the story.
And it's, with our friend, there's some things that are not real as we see them,
Mm-hmm.
but it's comforting to them.
Yeah, exactly.
It is comforting to her to remember or think something is a certain way, so you just let it be comforting.
Exactly. Yeah, there's no point in trying to argue, and that's something we're going to talk about a lot, because they're living in their reality, and they can't leave. So we have to kind of meet them where they are. And sometimes I feel like that too, but but we'll watch.
In the early stages of dementia with the person with the disease is important. At that time,
We're going to go back because she's a little quiet, and I didn't know that. Let me turn up the volume a little bit. Okay, and now we'll try hearing from Martha. Okay.
Communicating in the early stages of dementia with the person with the disease is important. At that time,
There
you
we
still
go.
have language as a tool. So you can learn things about what they might prefer as the disease progresses. For example, as the disease progresses, a person might have difficulty finding words. Caregivers often struggle to know what to do in that moment. Early on in the disease, you can ask. You can say, if you ever have trouble coming up with a word, would you rather that I jump in and give you the word, or do you want me to wait and allow you some time so you can find it on your own?
Yeah, and that's the nice thing about the early stage of Alzheimer's disease. We're able to catch it that early and realize that something's going on when someone is still in the early stage. We can have these types of conversations and ask how they want to handle communication. Some people are very proud and they don't want people to step in and try to provide a word for them. Other people might be that way when they're at home and they want you to let them try to find the word, but if they're in public, they don't want you to let them struggle and they want you to help them find their words. So it's just good to have conversations about that, but also about all these other things that we're talking about today when people are in the early stage of health coverage and legal and financial plans as well. We'll continue talking about the early stage. Like Martha said, we can ask directly how to help with communication when we're in the early stage. We do want to keep our sentences clear and straightforward, and this becomes more important as the disease progresses. We need to kind of take a lot of the fluff and the adjectives and the extra stuff out of our words. So instead of saying, oh, did you see the little boy with the green shirt chasing the blue ball across the street? Maybe we just take all the fluff out of that sentence and say, oh, did you see the boy run across the street? Just to try to keep things as clear and straightforward as possible. We want to leave plenty of time for conversations. And I think you're going to see something about patience or leaving extra time on all of the slides in this presentation, just because it is such an important thing to remember that we just need to take a little bit of extra time when we're talking to somebody with Alzheimer's or dementia. And we definitely want to include the person in conversations that affect him or her, including planning for the future. And kind of going back to, you never know what somebody's going to be experiencing or how their symptoms are going to be day to day. You never want to talk about somebody like they're not in the room, even if you think they might not understand what you're saying or they might not hear you, because you really don't know what they're going to pick up and what they're going to understand. And for somebody with Alzheimer's, one thing that we do see is that they might not remember what you did, they might not remember what you said, they may not even remember who you are, but a lot of the time they will remember how you made them feel the last time they saw you. And if you made them feel like they were less than you, or like you were talking about them like they weren't in the room, then you might not have a very good experience with that person the next time you go to see them.
I know, back to sentences, clear and straightforward. One of the big problems that you have with communicating is the undefined, like that or them, or instead of saying John.
Indefinite articles.
Yes.
Yeah. And you said they might have a hard time understanding those, and then they might start to use those things more often as they start to progress, because they can't remember people's names and they can't remember the names of items and things like that. So yeah, that's another thing that muddies the waters too. Continuing on in the early stage, like we were just saying, we want to avoid making assumptions because people's abilities can vary day by day. And sometimes people will make an assumption that once somebody has Alzheimer's, it's like once they're diagnosed, it's like, oh, immediate change. But it's really, they're the same person as they were yesterday. They just, now that they have this problem. And so, but there is a inclination from a lot of people to treat people differently, even when they're in the early stage, and they can still function pretty well. We want to speak directly to the person. Sometimes we'll see people, if they maybe run into somebody, a couple that they haven't seen in a long time, and it's a care partner and a person who's living with dementia, they won't even ask the person with dementia, oh, how are you? They'll just talk to they'll talk to their spouse or their care partner, because they don't even think they can talk to the person with Alzheimer's anymore. But we want to speak directly to the person, and again, not act like they're not in the room. We want to communicate in the ways that are most comfortable for people, and this is especially if you have somebody who lives out of state or if they live far away. People with Alzheimer's get confused, and so phone conversations can be confusing if that's not the way the person wants to communicate. Maybe texting is confusing if that's not the way they want to communicate. But you got to find out what's the best way for that person. Maybe if they really jumble up their words now when they're trying to talk on the phone, they'd rather send you an email or a letter, because they can really organize everything. So just doing things that are in the way that's most comfortable for them. It's important to laugh together. And of course, we never want to laugh at the person with Alzheimer's, but sometimes things happen with this disease that are just kind of funny. For example, people with Alzheimer's will have problems with sequencing. And so like doing things in a certain order. And so sometimes somebody with Alzheimer's might walk out of the room after getting dressed for the day, and they might have their underwear on outside of their pants. And of course, we don't want to laugh at them, but it's a little funny. And we can, and then we have to find opportunities where we can laugh with the person about what's going on, because otherwise if you don't laugh, you're going to cry a lot of the time. And so trying to find opportunities for humor. And being honest and staying connected with each other, and making sure, and trying to be open with friends and family members. A lot of the times when people are dealing with Alzheimer's or dementia, their friends and family will pull away. It's a very socially isolating experience a lot of the time. But sometimes we do see a difference if you let people know, hey, I still want you to be involved in my life. I'm still a person. I still need a social life. I still need my friends and family to be involved. Because a lot of the times people will just assume, oh, they're dealing with Alzheimer's. They don't want anyone coming over. They don't want, people stopping in and things like that. So sometimes you have to let people know that that's not the case. We'll move on to talking about communication in the middle stage now.
I have a question.
Yes.
Speaking of sequencing,
Mhm.
if the person you're taking care of puts the underwear on top of the blue jeans and we're going to Walmart,
Mhm.
do we correct somehow? How do you correct that appearance
Yeah.
of clothing is not right?
Right.
Is it okay to just kind of laugh and say, "Oh, hey, guess what? We need
Yeah.
to just make a quick change," or how do you? What's the best way to
Yeah, I
correct
think,
somebody that really can't
right.
do that?
Yeah, and like if they're gonna stay home all day, I say just let them do it.
Right.
But yeah, you do need to go somewhere. Yeah.
I would too, but if
Right.
you're going out.
If you're going out and you have to do it, I think kind of like you said, making it in a way where it's not, like you're not like, oh, I can't believe you did that. But like making it a way where it's like you just laugh at it and say, oh, we had a little bit of a mistake here. Let's try to go in and get changed a little bit so we can go out. Just trying to do it in a way where you're preserving people's dignity and not making them feel like they're like a kid or something like that.
You can always dress like them.
Yeah. Just make it, yeah. It looked normal.
Do I know
If the
you
whole
guys
family, if the whole family goes out with underwear on outside, it'll be, so,
We could call each other and say, okay, to church this morning.
Yeah, exactly.
The dress for the day is.
Yeah.
Got the memo.
Right. Yeah, that's a good question, though. Yeah, any other questions about the early stage or things like that before we move on? All right, well, we'll talk a little bit about the middle stage now. This is when people do start to have more problems generally with all the symptoms of dementia. They'll start to have increased difficulty finding the right words. And like we were talking about, they'll use familiar words repeatedly. So if they can't remember the name for something, but they still remember what it does, so they might call a pencil, like, oh, they can't remember the name for that. They say, like, hand me that writing stick, because they remember what it does, they just can't remember the name of it. They might invent new words to describe familiar things. Oh, that's more of like the pencil for the writing stick thing. But for the familiar words repeatedly, they might see some people who are calling everything a thingamajig or a whatchamacallit. We'll also see people easily losing their train of thought. So you might have you're having a conversation with somebody with Alzheimer's, and they might just stop in the middle of it and have no idea how to continue. And they might stand there for a moment, and they might be able to pick up that train of thought back, or it might just be totally gone, and they aren't able to continue the conversation. We'll see people speaking less frequently a lot of the time as they become less confident in their ability to use words, and they kind of become embarrassed having conversations a lot of the time. We will see people start to pull back a little bit and speak less frequently. And we will see people, especially in the middle stage, we start to see more often people communicating through the behavior rather than their words. Which is, when you start to lose your words and you can't communicate the needs that you have or the problems that you're having, you might just start to communicate through behavior. And so maybe what I mean by that is if you're, sitting, maybe you're at a community center or something like that, and you need to go to the bathroom, but you can't find the words to say, oh, I need to find the bathroom. That's what, you can't find the words. You might just get up and start walking around and opening doors and looking into places. And that's kind of what I mean by communicating through behavior. And it can look like a lot of different things. And we'll probably see some more examples of it a little bit further in the presentation. Yeah.
Would stuttering and not being able to get your words out, that definitely, in my opinion, would be a sign of maybe the beginning or middle stage. I don't know what stage you would look at that, but like my dad several years ago started, like, he couldn't, it's like his brain was trying to figure out what word came next.
Yeah.
And which that led to less communicate, him not speaking as much because I think it embarrassed him.
Right.
But I just didn't know if that was another sign of Alzheimer's or dementia, and maybe what stage you would consider that to be in.
If they're all like kind of like you were saying, they can't find the word, they're just like trying to start the sentence, but they just can't quite come up with the next word that they're trying to say. Yeah, I would, that certainly can be a sign, especially if it's happening a lot, like if it's happening every day and it's really interfering with communication. And that could be, like we said, the signs can be a little bit, especially with the stages, it can be tough to place, but that's probably early or middle.
That's been he's definitely in dementia. He has, progressed, but that was just kind of one of our
One of the first things.
we noticed was that he was having trouble getting words out.
Yeah, and new problems with words and speaking or writing is definitely one of the most prominent warning signs. Yeah.
Okay, well, before we go past this, what do we do if we suspect this in ourselves or someone else?
Yeah.
You can go to your primary care physician is the first stage to try to talk to them about it. I mean, how can they really diagnose early stage?
Yeah, that's a really good question. So the first place to go is to your primary care provider and let them know that, I'm having problems with my memory. And, and really, primary care providers really vary widely on how much knowledge and expertise they have on Alzheimer's and dementia. And so some of them, if they aren't taking you seriously, but you know that you're having a problem or that somebody else is having a problem, really advocate and say, no, I need you to do some tests because I know that something's going on. And so they probably do some basic tests at the doctor's office, like cognitive assessments. They'll probably screen for depression, do some blood work and things like that, because sometimes Alzheimer's symptoms can be caused by really severe depression, if that's something that you're dealing with. It can be caused by a vitamin deficiency. It can be caused by thyroid issues that are out of control. It can be caused by a lot of different things. So they're probably going to do a lot of physical tests to rule out everything like that. And they'll do some cognitive status tests probably. And then they might send you for some scans, like an MRI or a PET scan, to see if they can see any changes in the brain or to make sure there's not like a brain tumor or something like that that's causing these problems. And once they, rule out all of those things, and if they do see any changes in the brain, then generally they'll give like a diagnosis of dementia, like there is some sort of dementia going on. But dementia is really an umbrella term, and it describes a lot of different conditions that can cause it. And Alzheimer's disease is the most common cause. We think about 60 to 80% of dementia cases are due to Alzheimer's disease, but there can be a lot of other types of dementia too. For example, you might have heard that Bruce Willis was recently diagnosed with frontotemporal dementia. That's another type of dementia that's less common, but it does happen. But I'm kind of getting off track now. But they'll diagnose you if you're having these problems and it's not due to anything else. Then usually your primary care provider can give you a diagnosis of dementia generally. And then they might refer you to a specialist to try to see what specific type of dementia you might be dealing with. The specialist would usually be a neurologist or a neuropsychologist, maybe a geriatrician. And the wait lists to get in to see those folks are really long, usually about 6 months. So people do usually have to wait quite a while to see and get that more specific diagnosis. But generally, when people do get the first diagnosis, their physician will be able to start them on maybe some medication to help with memory and things like that. And so it's still definitely worth getting the diagnosis, but it's worth it for a lot of reasons, because you're making sure nothing else is going on that can be remedied, like a vitamin deficiency. But you're also, kind of providing peace of mind for the people who live with you too, because sometimes when you're a care partner for somebody living with Alzheimer's and they start to show symptoms, but you don't know, but no one knows what's going on, it kind of feels like you're like, what is going on? Am I losing my mind? Is this person losing their mind? What's happening? And so it really helps to have the understanding of what's going on too.
You indicated like a roughly 6-month lead time to get into a specialist.
Yeah.
How long from the time you go to your primary care and say, I'd like to get referred to a specialist, does all this testing that you're talking about in between take? That sounds like it could be up to a year.
It could be a while. Usually the testing that your primary care physician does doesn't take a very long time. Usually most of the tests that the initial test that they'll do during your first visit, and then you'll go and do the lab work, which will, might do that day or, within a few weeks. And the same with the scans, it might take a few weeks. But then when you really, when you go to a neuropsychologist, for example, then those tests can take, that's like a marathon. It's a whole day of verbal and written testing and things like that, that you've waited for 6 months for. So there's a lot of hurry up and wait that goes on.
And then what's the importance of and how effective is early detection regarding medication and intervention?
Yeah, so we do see that the medications that we have to treat the symptoms of Alzheimer's they seem to work better for people when people are diagnosed early. And so kind of the way that the medications that treat the symptoms work, like Aricept and Namenda and those types of drugs, generally they help people kind of they help people's symptoms not progress as much, but the overall disease the overall disease is still progressing. And so those do work better when people are diagnosed early. The drugs that we have to try to treat the plaque buildup that's causing the symptoms of Alzheimer's disease, which are called Aduhelm and Leqembi. They've only been approved very recently. Those are, you're only able to be on those drugs if you're in the early stage. And like you said, the Medicare will only pay for them if you're in a clinical trial. And so, yeah, those are a little bit harder to get on, but they are more effective. You're only able to get on them if you're in the early stage, and so that's another reason to be diagnosed. And then the other big reason that we talk about is planning, because most of us don't have our advanced directives and all of our legal and financial things in place. We all should, but most of us don't. And there are a lot of things that need to be changed sometimes when somebody is diagnosed with Alzheimer's. For example, when you have Alzheimer's disease, you shouldn't be anybody else's power of attorney, but you're probably your spouse's power of attorney. So that's at least one thing that's legal that needs to be changed, probably. But there are a lot of other things to look at too, especially advanced directives, because as you get more advanced in your disease, you're going to lose legal capacity probably. But you do still generally have the capacity to make legal decisions when you're in the early stage. I think it's generally the attorney has to decide. We might hear more about that in a little bit. But yeah, the early planning is really important for the early diagnosis too. Even just letting people know about what you want to happen as you go through this process. Do you want to stay at home for as long as possible? Or are you open to going to a long-term care facility? So those are things to think about too. Really good questions. Any other questions before we move on?
One more.
Okay.
Sorry.
Oh.
But you mentioned trials.
Mm-hmm.
How would the primary care physician be the one to be aware of those? Or how would you, if you, assuming that you needed it,
Right.
How would you get involved with trials?
Yeah, here in Tulsa, the best two ways to do it, the primary care providers generally don't know about that
Right.
type of thing. The best two ways to do it are, one is through the Alzheimer's Association. We do have a clinical trial matching service. It's called Trial Match. And people can go onto that website. You can put in your health and demographic information, and it pulls up a list of trials that you're a match for. It doesn't send your information to anybody. It's confidential. But it gives you the phone numbers to call if you want to get involved in that. Yeah, and then the other resource that we have here in Tulsa that's really cool is a place called Central States Research. It used to be called Tulsa Clinical Research, and they have been doing Alzheimer's research since the 80s. And they were involved in the first trials for Aricept. And most people don't know that they're here in Tulsa, but they are still involved, and they're still heavily involved in Alzheimer's research. They have 4 or 5 Alzheimer's trials going right now. And so sometimes calling them is a really good way to see what trials are going on and what you can be involved with. Also, if you're ever worried about your memory, Central States Research offers free memory screenings. So they can kind of give you an idea of if you might should be worried. The only thing, obviously the reason they do that is so they can get trial participants. So they're probably going to ask you to be in a trial but just, it's good to know that.
On the internet, there is a very simple thing that you can do that's supposed to show if you have any symptoms of it. I've done that. Yeah,
and of course that can be helpful, but you always want to be a little bit careful because those things can scare you a little bit sometimes because it's just not usually for it to be really considered accurate. You just want to get it from a medical professional or a doctor, but those things can be helpful just to let you know if you might have a problem where you want to go to see a doctor or somebody.
Well, it was about the same thing the doctor did for me when I went to have him check me.
Right. Yeah.
It's almost the same.
Yeah.
Simple.
So yeah, those are definitely a tool to use. Yeah.
Is there a time, a length of that is better for taking like Aricept? My husband was on Aricept for a long time.
Mm-hmm.
And then they changed him to galantamine.
Mm-hmm.
And, they talked about trying to take him off of it. And I said, well, then he can move in with you. If you want to play
Suddenly they got more cooperative.
Yeah, I bet.
So, they kind of look at me like, what? And I said, I know what I'm talking about.
Yeah.
So is there a time length or is there, what I was wanting, because they've been talking about trying to take him off of galantamine, and I'm just going, no.
Right, and it's, it's gonna be, whatever you and the physician decide, because with Alzheimer's, everyone experiences a little bit differently. Once you've seen one person with Alzheimer's, you've seen one person with Alzheimer's, and so we really do kind of have to look at it on a really individual case. So, but I think you're doing the right thing by not just doing necessarily what your doctor says and having a conversation and advocating, because sometimes you have to. Because they'll just say, okay, we're going to do this, and you have to wait a minute. I don't think so. But it's so individual that it's hard to make a general statement. All right, any other questions before we move on? All right. And I'll finish up on this slide. You see here the asterisks on the bottom. Consult a doctor when you notice major or sudden changes. The progression of Alzheimer's and other forms of dementia should really be a slow and steady kind of decline. It shouldn't be anything where it's really like a quick decline over a certain quick period of time. And sometimes when something like that happens, it's because there's something else going on that's exacerbating their symptoms. So sometimes like urinary tract infections, for example, or other things like that can really exacerbate dementia symptoms if people are dealing with those. So if somebody is talking in full sentences one week and then the next week they're reduced to a few words or phrases or something, that's certainly a quicker progression than what we would expect, and we'd want to call the doctor if something like that happened.
I would advise couples, and I usually do advise the caregiver who comes to the group and is caring for a spouse, that you take your time. Always count to 3 before you respond, because it gives you time to think about your answer and what's going on. Generally, in a marital dispute, it's quick, it's back and forth, you're quick to give an answer. When they've been diagnosed, to sit back and say, okay, you're supposed to be the one that's reasonable here. Let's change how we do this, because there's only one thing you can control, and that's you. You cannot control them and their process.
Yeah, I really like what she has to say there, especially thinking about like, okay, I'm the one with the healthy brain. I can't control their process. I can't control their disease. All I can control is my actions and how I react to it. And really, that's what we have to do. And so we'll talk about communication in the middle stage a little bit more. So to connect, we can approach the person gently. And when we're approaching somebody with Alzheimer's disease to have a conversation, we do want to approach them from the front because as people progress through the disease, the part of their brain that deals with vision starts to have problems. And so a lot of the time they lose their peripheral vision. And so if you come up to somebody from the side, that can be really startling. And say who you are and call the person by name. So for example, if I was taking care of my dad, I might go up to him and say, oh, hi dad, it's me, your son, Jacob. I'll be, helping you take your medicine today. And so that way I've addressed him, I've reminded him of what my relationship is to him, and I've reminded him of who I am and what we're going to be doing. And so that helps make things a little bit less startling when you're going to help somebody with something, and it helps make them, maybe a little bit less embarrassed where they don't have to struggle to remember who you are or what's going on. It's good to maintain eye contact because people with Alzheimer's do get very easily distracted and lose focus, and maintaining eye contact can help with that. And get at eye level if they're seated or reclining, because sometimes when somebody's in a wheelchair or something and you're standing over them, and especially if you have like a uniform on, like you're a CNA or something like that, it's really intimidating. That goes back to the body language thing we were talking about, where if you're just standing overlooking somebody, they might be scared of you. So it's good to either pulling up a chair and sitting with them is usually the best thing to do, because sometimes kneeling down can kind of be a weird body language thing too. But if we do need to kneel down to get on their eye level, that's still better, and trying to talk with them that way. And then we talked about this earlier, but avoid criticizing, correcting, or arguing. You'll never win an argument with somebody with Alzheimer's disease. They are living in their version of reality. Their perception is their reality, and they can't change it. So we have to meet them where they are. Pay attention to your tone, and this can be really hard, especially if it's like, okay, dad came out of the room, he has his clothes on in the wrong order, and we need to go to the doctor's office, and we need to do this quickly. And sometimes it's really hard to pay attention to your tone in situations like that. But we have to remember that we're probably only going to make the situation worse if we don't. And again, take your time. I was talking with one of our volunteers earlier this week, and she was talking about, yeah, when I would take my mom to her doctor's appointments, I would show up to her house an hour early because I would tell her to be ready at 8. But what she heard was, oh, I'm going to be ready for you to get me ready at 8. And so, it's sometimes just leaving a lot of extra time for things because things just take longer than they used to.
She could sense my frustration. Because occasionally I would lose my patience and I would bark at her. Why are you asking me that question again? I just answered that question 2 minutes ago. And then she would get frustrated because, she was very old school and she's like, don't disrespect me. And I didn't ask you that question 2 minutes ago. It's a new question. So phase 2 of our relationship was like, okay, that's a new question. I'll answer it again.
Yeah. And that's the important thing to remember is they really can't. They just don't know if they've said the same thing over and over again, or if they are trying to leave and they're not supposed to. They just don't know any better. Yes.
My husband he's always in a hurry
Mm-hmm.
for that thing, and he says, "Now what time are we going to leave for church?"
Mm-hmm.
And then 2 minutes. What time are we going to leave for church? So I have started when he does that to get a piece of paper and write on it. We leave for church at 8:20.
That's a really good idea.
Put that in front of him, and he'll say, "What time?" And I say, "Look at your paper."
Mm-hmm. Yeah, doing things like that for people is really helpful, giving people visual aids and reminders. Yeah, and that's another really common thing that we'll see is people with Alzheimer's will sometimes have a hard time understanding something if it's not happening immediately. And so the passage of time and things like that become confusing. Yeah.
There's research that says that engaging a different part of the brain.
Mm-hmm.
And so, she was responding to an auditory thing,
Mm-hmm.
and now you've engaged visual.
Yeah.
So
Maybe you're using
it's
some different pathways.
working around those
Mm-hmm.
different areas.
Yeah, I think, trying to get to people in different ways and using different parts of the brain. Yeah, that's a really good idea. And providing visual aids, sometimes you can't write things down, but maybe you can use charades. Or one of the things we talk about a lot is we'll have a hard time getting people to eat. I know Martha has talked about this a long time before. Okay, yeah, I'll hurry up. But yeah, using different parts of the brain is good.
Again, I'm sorry.
We'll finish up talking about the middle stage. To connect, we want to keep it slow and basic, using short sentences and basic words. Speaking slowly and clearly, one question and one person at a time. And again, we do want to limit distractions because people can get very easily distracted. Be patient and offer a guess or fill in words if that's acceptable, if we've talked about that before and we know that's something that they'll be okay with. And to connect, we can give multiple cues, and this kind of goes back to what we were just saying. We can provide visual cues and gestures. We do want to avoid sudden movements because that can be frightening. Write things down for the person, there we go. And put answers into your questions because sometimes open-ended questions can be really confusing for people. And so instead of saying, what do you want for lunch? Maybe you can say, I'm making lunch. Do you want a turkey sandwich or a ham sandwich? Because then you've kind of put the answer into your question, but you've also still given them a choice. Put answers into your questions, repeat things as needed, turn negatives into positives, and avoid quizzing. But there used to be this assumption that if we quizzed people, we would help them remember. But now we just know that it just makes them more frustrated and it doesn't actually help. To connect, we want to respond empathetically to people and reassure them. Because there is a lot of fear and confusion that comes along with Alzheimer's disease a lot of the time. So we want to, as much as we can, join the person's reality, try to figure out where they are and what's going on and meet them where they're at. And provide reassurance that you hear and understand, even if maybe they're talking about something that isn't real. If they're, if they're trying to talk about the conversation that they had with General Patton this morning, and they're getting frustrated because you won't listen, and you're trying to say, oh no, General Patton died in 1945. There's no way you had a conversation with him. But just providing reassurance that you hear and understand, and just letting them tell you what they want to tell you. Focus on the feelings, not the facts. And sometimes even if you can't understand what is upsetting the person, sometimes just focusing on the feeling that you can see, like, oh, I can see that you seem sad today, or do you miss the way things used to be? I miss the way things used to be too. validate and redirect the person as necessary. So we do want to validate whatever their reality is, and then, but sometimes simply that validation isn't enough, if they're really stuck on something, and we have to redirect them away if they're upset and they're really focused on something that we need to get them off of. For example, one of our volunteers who gives this presentation, she was taking care of her mother-in-law, and her mother-in-law would go into her bedroom every afternoon almost and start packing her bags. And she'd say, oh, you know, where are you going? Oh, I'm going to go see my parents in Dallas. And obviously, you know, this woman was in her 80s. Her parents had passed a long time ago. You don't want to tell them that because then they relive the grief over again. And so she would just say, oh, you know, okay, well, it's a little late in the day to drive to Dallas. It'll be too late in the night. So let's just pack things up and we'll go tomorrow morning when we can get an earlier start. And usually that would satisfy her. And she'd say, oh, okay. But sometimes she wouldn't, and she would need to be redirected because she would get really focused on, no, I haven't seen my parents in a long time. I'm going to go see them. And so but she knew that her mother-in-law really liked seeing the hummingbirds in the big picture window in the front of the house. And so she'd say, okay, well, we can do that. But first, I just saw some hummingbirds in the feeder. Do you want to go look at those? And that would, she'd get excited about that. And they would sort of be able to redirect her away from what she was doing. And then while they were doing that, her husband would come in and unpack all the bags and put the suitcases away. And so that they would solve the problem in that way. So, but sometimes those are the kind of things you have to do. And it's not lying, it's therapeutic lying, right? And we'll talk about communication in the late stage. Some of the changes we notice, like we said in the beginning, communication is reduced to a few words or sounds, but people will still have possible responses to familiar words or phrases. But to connect, we want to listen to expressions of pain and respond promptly, and do whatever we can to help the person feel safe and happy. We do want to continue to bring respect into each conversation because we do want to still treat these people like adults as much as we can. And keep talking. Sometimes our inclination is if they've stopped talking, then we stop talking too. But really, they probably want to continue to hear the sound of our voice so that they know we're still there. So we encourage people to keep talking and use all 5 senses to communicate. And we'll spend a little bit of time talking
I know
about
that my mom feels aggravated. I know that she feels alone. I know that she feels confused. And I know on any given day, I don't know if I've made it better for her. I tried. In these later stages, I've come to recognize that being really aware of the 5 senses is really important. Touch seems to give her a great deal of comfort. I know when I come over, I'm going to brush her hair all the time. My husband noted to me recently, he said, you know, you should see the look on your mom's face when you're brushing her hair. She's just happy. She's just happy. She doesn't say a lot. And I do it for a long period of time. I comb it, I braid it, I do funny things with it, but it just allows me to just be with her in a way that makes her feel comfortable.
Yeah, and that's really what we need to find is just a way to be with people in whatever way makes them comfortable. So we'll run through this really quickly, some ideas for connecting with people in the late stage through each of the 5 senses. The first one we'll talk about is connecting through touch. There's a lot of ways we can do this. I think visiting with animals is really powerful, especially therapy dogs and cats and things like that. With the caveat of if the person wasn't an animal lover before in their life, they're probably still not going to be, so remember that. Sculpting and doing art projects, but simply just sitting with someone and holding their hand or wrapping your arm around them can provide a great deal of comfort. Connecting through sight, one of the best things you can do is looking at old photo albums together. I do say old photo albums because we do know that long-term memory lasts a lot longer into the disease than things that are more recent. So they might not remember grandkids and things that have happened more recently, but if you show them pictures of like their wedding or their high school graduation or things that happened a long time ago, those might be things that you'll get more of a reaction from. Yes?
One of the things that research talking about the brain structure is the electrical memory versus the chemical memory. Mm-hmm. And so long-term is chemical, recent is electrical.
Wow. And
so that when you connect to the chemical memory, it's usually the last to go.
That's really interesting. I'd not heard that. Thanks for sharing that. And one of the other things is simply going outside and being around nature can be a really powerful thing as well. Going bird watching, going to the aquarium or the zoo. We started a program in Oklahoma City recently that is specifically zoo tours for people living with Alzheimer's. That I'm really excited about. Connecting through sound, listening to familiar music is one of the best things that we can do. Even especially music that has a really personal meaning for people, especially if they're a person of faith, like hymns and religious music. You might see people who have not been able to say a word for a year, but they can still sing every word of their favorite hymn or something like that. Music just works with a different part of the brain. It works with the brain differently, and it's really impressive. There's also listening to songs or speech in the person's native language. It's important to remember that if they're not a native English speaker, their English is probably gone by this point. And so doing things in a native language is going to be better. And just simply reading things to the person, talking to them, letting them hear the tone of your voice. Smell is also, we talk a lot about how smell is linked to memory and some things like that too, especially early from a long time ago. We can do a lot of things to connect with people through smell. I think essential oils are especially interesting, either whether you're dipping them in cotton balls and kind of putting them in bags like this suggests, or using a diffuser to kind of get it throughout the entire house. But it does seem to be able to, it's sensory, but it's also can be relaxing for folks, it seems like. Also tea or coffee beans, that's everybody loves the smell of coffee, right? And then my favorite, connecting through taste. Yeah, there's a lot of different things that we can do here. Feeding people favorite foods is one of the best things that we can do. Sometimes people get really, they get focused on nutrition in this late stage, and that's good that they, because of course we care about the people, we want them to be healthy, but when somebody's in the late stage, if all they want to eat is pancakes and syrup, I would say let them eat pancakes and syrup every day. Home-baked goodies are also great. And then, when people in the late stage, they do, especially towards the end, start to have problems with swallowing. And so that's when things like popsicles, flavored drinks, ice creams, and puddings can become even more helpful. Okay, we got our last slide here, and then I will give over the stage to our next speaker. But just to recap, the most important thing to remember is to join the person's reality to connect, and making sure you're meeting them where they are. And understand and accept what you can and cannot change. And really, we cannot change the disease and its progression. All we can change is how we react to it. Remember that the person retains of self despite the losses of the disease, and that's true through every stage. Demonstrate respect and communicate through feelings. Always treat the person as the adult that he or she is, and try to decode the person's communication, especially when they're communicating through the behavior instead of their words. Recognize the effects of your mood and actions. I'll tell one more quick story before I leave. When I first got to the Alzheimer's Association, to the Oklahoma chapter, we were working with a family here in Tulsa, and the husband was the caregiver and the wife had Alzheimer's, and they had a daughter that lived out of state, and she'd flown in to try to help out because the wife was having all these behaviors. She was having a really rough time. The household was going through a really tough time. And so the husband and the daughter came in for a care consultation, and one of the things that we talked about was recognizing the effects of your mood and actions, because he was having a really hard time too with all this. And so the daughter came back a couple of months later. Everything was much smoother and calmer. A lot of the behaviors have subsided. And she said to her dad, what happened? Did you get mom on some sort of medication? And he said, no, but I started taking Xanax. And it was because he was having such a hard time with all the stuff that was going on that his anxiety and his stress and his mood was totally overflowing. It's contagious, exactly. And so we have to recognize the effects of our mood and actions too. Try to understand the source of reactions. Sometimes dementia-related behaviors seemingly come out of nowhere, but sometimes there are triggers we can identify for things. So sometimes, for example, if somebody gets upset or at the same time every day, and maybe it's because there's a show that you're watching. Maybe they're getting upset at the evening news is coming on, and they're seeing the shootings and the bombings and all these horrible things that are happening, but they can't understand that that's not something that's happening right now to them. And so that might make them really upset. And so looking for triggers in the environment and help meet the needs of the person while soothing and trying to help them calm down. And then one more.
Taking care of yourself while you care for somebody with disease not only impacts your own health, but it really can impact the person with disease. So for example, if you're not getting enough sleep, you might be easily irritated, which will then sort of spill over to your interactions with the person with disease and maybe being short with them, which then might cause them to get frustrated. So it's not only important to take care of yourself for your own health, but really for you to really be a good caregiver.
Yeah, I know we're short on time, but I did want to let Dr. Fazio say that because I think it's really important to talk about caregiver self-care. And it's also, I'll leave you on this slide about a 24/7 helpline. I always tell people, if you only remember one thing that I say for my presentation, I hope it's the 24/7 helpline, because it is the best resource the Alzheimer's Association provides. I work 9 to 5, but that's not Alzheimer's hours. Alzheimer's hours are 24/7. Sometimes you do need someone to talk to at 2 a.m., if there's something going on at that time, like your loved one's trying to leave the house and you need, how do I stop that from happening? You can call the social worker at the helpline, and they can help you talk through that situation and resolve it. Maybe 2 a.m. is the only time where your loved one is asleep, and it's the only time where you can actually talk to somebody about what's going on. So whenever you need to reach somebody at the Alzheimer's Association, you can. They can help with questions about Alzheimer's and dementia, but they can also help you find resources. If you're looking for a neurologist, if you're looking for a home care agency or somewhere for your loved one to live, they can help you with that kind of thing too. And we aren't like two separate organizations. Like, I talk with the people at the 24/7 helpline. So if you're ever looking for something locally, they can just send me a message and give you my contact information or have me call you. So you can always get in touch with your local chapter too. But I will yield the stage to our next presenter now.
Thank you.
Boy, I don't know. Do we keep going or do you want to take a break? You guys want to keep going?
Keep going.
No, get off. Are you okay with staying a little bit? I'll do anything you're okay. Absolutely okay. What's waiting for me are chores. Okay, so I'm delighted.
There's two.
Well, that will limit the presentation if I have to go. That'll help me to do it. So I'll just tell you all, she's getting me set up. I'm not very technological, so I'm delighted she's helping me set my speech. I'm Stephanie Mitchell. I'm a lawyer here in Tulsa, and my practice for the past 4 years has been focused on special needs planning and Medicaid crisis planning for folks who need it. Thank you. Thank you. Little tutorial there. In addition, I've been doing estate planning, trust, and probate litigation for 8 years. And before that, I did awful stuff. Medical malpractice defense, insurance defense, litigation, stuff like that. So I've put fights in the courtroom behind me mostly. And now I try to help people plan for the future, but when the plan goes wrong, I can go to the courtroom if we need to. So I think Jacob said it, and I appreciate these speakers so much. I learned a tremendous amount, so thank you guys for going first and letting me take notes. Advanced planning is the best when it can happen. So I thought I might run through some of the estate planning vehicles or techniques that we have that you all can use if it's appropriate. But it sounds like maybe we need to spend some time in crisis planning and talk about alternatives to a plan. So that's what I've got. Let's see what happens when I push this.
You should have handouts on your table too as well.
So we're in a church. I'm a believer. A lot of what I do and how I approach my clients is with a spiritual focus. And while we try to plan and put things in place, what I'm confident about is that our Creator loves us, cares about us, has been with us all along, and isn't about to stop wherever we are. So I just threw in a little Proverbs: without consultation, plans are frustrated, but with many counselors, they succeed. And this morning, you have at least been exposed to 3 people who, well, you can decide about me later, but 2 who are really good helpers. So estate planning, the idea is planning for the lifetime care of your person. I'm thinking of you all as caregivers. But of course, you can apply this to yourselves who may need care at some point. And so the best thing we can do is sort of plan ahead if we can, make your wishes known. And both of the speakers have talked about that already. And estate planning governs or has an opportunity for you to make plans about your person, your stuff, and what happens to both when you're not calling the shots anymore. So I didn't realize I'd have to push this twice. I may have to push this a lot of times. So basic tools, and I'm just gonna push them all and then talk about it the way I like to talk about it. So I do an estate plan, a complete estate plan I consider to be 5 documents, a will and a trust. The will pours over anything you forget to put in the trust, into your trust. And then we can talk in detail about what a trust does, but then a healthcare power of attorney and a durable power of attorney is the document that stays in force once you, the creator, have lost the ability, you're incompetent. So that's what durable means. And then advanced directive for healthcare. The advanced directive is what you guys have probably heard called the living will. That's the pull the plug document. It's also the document in which you can decide to make tissue and organ donations, and then for what purposes you would make those donations. So the care of your person involves a healthcare power of attorney. In that document, the principal is the one signing it. So the principal names an attorney in fact to make healthcare decisions. They can, if you include the HIPAA language, that document enables you to get your helper to get your health information. It can avoid a guardianship over the person because you're authorizing someone while you're competent to make decisions for you when you aren't. And those decisions really can cover a lot. Healthcare, what you get in terms of healthcare decisions that you may not have thought about, but you're trusting that person to decide. Long-term care, stuff like that. Your attorney, in fact, is not authorized to make end-of-life decisions, so the pulling of the plug. That's what you do in your advance directive. And also in that advance directive, you can name a healthcare proxy.
I'm sorry, your end-of-life decisions, the healthcare, whatever that is, power of attorney, that does not include DNRs.
So,
because, I mean, as far as what I understand, you have to fill that out separately.
Yep, there's a separate document for a DNR, and your advance directive is going to govern or cover 3 specific instances: terminal condition, persistent vegetative state, and terminal. Did I say that? I don't remember what the 3 are right now. There are 3 conditions. And that document, the advance directive and the power of attorney, those are statutory documents, which means there's a form of them in the law books. So you guys don't have to hire a lawyer to put that in place. You can print out of the statute, sign it, and it'll do what it does. The reason you might hire a lawyer and get a fancy one, mine's 18 pages long, is because the statute says any power not specifically given isn't given. So my 18-page power of attorney for healthcare lists out specific decisions that you're authorizing the person to make. So you're right, you can't make end-of-life decisions in an advance directive or a healthcare power of attorney, but you can be pretty darn specific. And so that's one reason that you might consider hiring a lawyer to do some of these documents. So your advance directive, those 3 conditions, you're deciding if you want everything medically necessary to help you through it, nothing except artificial nutrition and hydration, or some, and it's a hybrid. So that's you're checking those 3 choices for the 3 conditions. I don't want to waste your time trying to wonder what they are. I can tell you after this if we want to talk about it in detail. And that advance directive also authorizes a healthcare proxy. There are other documents that are more detailed in dealing with end-of-life decisions. The DNR document, there's a document called a POLST. It's a physician-ordered life something. Thank you. So in that document, you can read the choices and be more specific. And then the doctor is entering those orders in your medical chart, and it sort of acts a different way. So those are the documents that cover your person. Yes, sir.
I just had a quick question. We have a will, and we had it done through a lawyer, but it was in another state before we moved here. But since we moved, we were in Louisiana, now we live here. Is there any reason that nothing's changed in it except an address? Legally, is there any reason that I need to go and get this updated with a new address? Do I need to do that because I moved to another state? Is it not valid anymore?
So I am going to answer the general question. The full faith and credit clause of the United States Constitution tells state courts to honor the laws of other states, right, when they're brought into them. And if your Louisiana will was executed with the proper formalities to make it valid in Louisiana, it can be probated in Oklahoma.
Okay.
The question you asked that I'm pausing from is there any reason I need to change it? There might be. I hear you saying that there aren't any new circumstances, but in making plans for future and in contemplating things that could be done, for example, in conjunction with a trust, there may be a reason to change your will. So I think it's a really good idea to, I tell my clients, 3 to 5 years, you're re-looking at your estate plan and kind of wondering, has any circumstance changed? Has someone passed away that I've given all my stuff to? Is one reason to look at it. You can look at it 3 to 5 years to see if any laws have changed, and then your objectives may have changed. So 3 to 5 years, if you have an existing estate plan, you might consider pulling it out and thinking about it. So switching now to thinking about the estate plan tools that govern your assets. The goal in making a plan is to determine that, number one, if someone needs to be appointed to help you deal with your stuff while you're alive, but maybe incompetent, and that incompetence could be temporary or permanent. So that is the circumstance that you would use your durable power of attorney for finances. I do separate documents, power of attorney for healthcare, power of attorney for finance, because my doctor doesn't need to know what all my financial plans are, and my banker doesn't need to know what my healthcare plans are. So, and you're publishing that document. I mean, you're going to take your power of attorney and you're giving it to the person that you're trying to affect, right? And so that's why we keep that stuff separate. The power of attorney, there are 2 of them. One is an immediately effective one, and one is a springing power. The springing document doesn't, you're not giving the authority to the person to act for you until you've been determined to be incapacitated. So even though you sign it today, the person that you've named can't do anything for you today because you haven't been determined to be incapacitated. Usually that takes 2 doctors' certifications. So that is positive because it delays anyone's getting in your business, but it can be negative in that if there's a circumstance in which you need someone to be able to help for you, they've got to stop, drop, and roll to go get 2 physicians to determine that you can't do it yourself. So I recommend people do the immediately effective power of attorney, and they just choose someone whom they trust implicitly. My document requires that the agent give notice upon the first use to the principal. That works if we're cooperating before the person is fully incapacitated. It doesn't really work that well if the person's incapacitated. For example, they've been bonked on the head and they can't tell me, yes, please go pay my mortgage, it's due today. So those are the ups and downs on the power of attorney and the immediately effective. You can continue your gifting by using a power of attorney if you get a lawyer to write one, because that gifting power is not in the statutory form. But for example, continue my tithe, that sort of thing. Asset management, investment powers you would give someone. And again, here, if you've given someone authority to act for you financially, then when you are fully incapacitated, no one needs to get a guardianship, because in order to get authority to act for someone when they're incapacitated, you either have to already have it or you have to go and get it. And where you go and get it is in the guardianship court. Nothing wrong, and I'll talk about a guardianship later, but there's nothing wrong with the guardianship process. It just takes time. In Tulsa County, we have one guardianship judge, and his docket is really long. And so when I file a petition for guardianship for someone, I'm waiting 3 or 4 or 5 weeks for the hearing for them to get appointed. There is an emergency process, though. And then in the power of attorney, I usually give my attorneys, in fact, the ability to do estate planning for their principal if he hasn't done it. So you don't have to do a power of attorney to have control over a particular piece of real property or a piece of property with a title, like a car. If you own it jointly, then joint owners can do stuff, right? So if you have a joint bank account and the other owner becomes incapacitated, the joint owner can just keep acting and doing things. So same thing, you could transfer your car title if it's a joint title. Piece of property, you can act jointly. There are risks with a joint ownership because each owner has full authority over the whatever it is. So you want to be joint owner with someone that you trust that isn't going to take it, close it, etc. You can avoid probate if you own a piece of property jointly because title passes by operation of law to the surviving joint owner at the death of one of the owners. There you go.
So what you're saying is, I'm trying to simplify it for me. On the title, if it says husband and wife, or if the title says husband or wife.
So that will work on a car. That won't work on a piece of real property. Real property to have and a bank account. To have survivorship rights, it must say survivorship. So that's what you would see on your deed. It'll say joint tenants with right of survivorship.
What about an on-death deed?
Transfer on death deed is another kind of deed where you can transfer your property after you've died by titling the property with a transfer on death deed. And that says, I'm not going to give you the deed language, that's confusing, but it'll say Stephanie Mitchell and on death to Jack Coates, who's my son. The trick with that one is that the statutes require the beneficiary to record the death certificate, an affidavit of survivorship, and the new deed in his own name within 9 months of the death of the principal. So that timeline matters. If it's not done, then you got to do a probate to get that piece of property into the next person's name. So the principle here to understand is the only way to transfer title to a piece of titled asset, a car, a vehicle, a boat, a piece of real property, after someone has died, is through probate. Your will tells the probate judge where to dole out the assets.
But doesn't force it.
Right. The action of transferring title is with that judge's signature on your final order in the probate. So that, I'm getting out of order. You can tell I'm not good at this. No, this is a great conversation. So if you don't have a will and you don't have a trust and you die owning a titled piece of property, to get it to the next person, if it's a joint tenant, right, that joint tenant simply files an affidavit of surviving joint tenant and records it in the county land records, and that property then, the title vests automatically by operation of law on that surviving tenant. If you own it individually, you got to go through a probate. If you don't have a will, the state of Oklahoma will decide who your heirs are, and it's in the statutes. If you do have a will, then you are telling the judge where my assets go. If you put your property into a trust before you die, and you die, you don't own anything, the trust owns it, and the trust continues. That's the value of the estate planning tool that I suspect we'll come to next. So a revocable living trust is the creation of an entity that is an alter ego of a person. So you are if you create it, you're the grantor, you're the trustee, you control it, and you're the primary beneficiary during your lifetime. So whatever the terms of the trust are is what happens to your stuff for your benefit while you're alive. And while you're competent, you're the trustee. You're calling the shots. You're buying, you're selling, you're living, you're using. If you become incapacitated, then you've named another trustee who steps up and just administers it for your benefit until you pass away. And then they distribute the assets, or perhaps it continues. It avoids the probate. It can also avoid guardianship because you've already appointed a trustee who's in charge of the assets that have been put into that trust. It's great because it is, you avoid creditors. In a probate, the process is public. So you're down at the courthouse. In Oklahoma, almost everything that happens in the courthouse is a public record. So it's published on the Oklahoma Supreme Court network, and people can log in and look and see what old Uncle Bob left and who's getting it. It's an opportunity for creditors to come in and talk about what the deceased person owes, and there's a process for them getting paid. It's difficult to attack by heirs someone who thought they were going to get something or want something.
That isn't to say that trusts aren't litigated. They are. There's a process by which you can complain about a trust, but it is kind of difficult to get there. So the trust is also more flexible. Whereas you have a joint tenant deed and you just know if one dies, the other one's getting it. The trust can allow for several options. If this, then that, but if this, then that. And so it's a little bit, you can exert more control over your assets by putting in a trust.
That leads us to the next question, which is the one about what I call the Medicare clawback, the 5 years.
Yeah.
Yeah.
So that is right. Medicaid is a means-tested program that pays for long-term care for folks. And the means test we can talk about. I had planned to sort of get to that at the end. If you want me, I can do it now, or we can kind of
Just wait, we'll
go. It's late, you guys. Yeah, thank you. On your table, if you have to go, is my business card and this presentation. And if it triggers any questions, feel free to give me a call or an email anytime you want. But so if you have capacity for the person you're caring for, they have capacity, which means they understand who they are, the nature and extent of their estate, what they have, if they understand the natural heirs of their bounty, who would normally get their stuff, we can do an estate plan, and they can make advanced plans about who they want to be their helpers and what they want to have happen with their belongings, whom they would like to be their guardian if they need one. And so planning is, in my mind, the best way to go. This is more specific on, and it's in your materials on your table if you want to, more specifics on why you might use a trust. There are such thing as irrevocable trusts. That's a trust that cannot be changed after it's made. The revocable trust that I do, when you make it, you can sign it on Monday, revoke it on Tuesday, and make a new one on Wednesday. It's a living, breathing document meant to be amended or restated as needed. You can, on the death of the grantor, it becomes irrevocable, and then it's just to be administered or his wishes to be carried out. There are strategies and reasons that you might want to create an irrevocable trust that can't be changed. If you need to get assets out of your estate to avoid estate tax, then you can give it away. You can't get it back. You can still get some of the benefit of it. For example, you might could collect the interest on a particular kind of asset, but you don't have it anymore, so it won't be in your estate when you die. The estate tax exemption amount right now, y'all, is $12.9 million per person. I'm not doing a ton of tax planning for people because not that many people have that much stuff. But an irrevocable trust is a tool for that. It can be a tool for Medicaid planning. So Medicaid is a means-tested program that will pay for long-term care, but also it's health insurance for impoverished people. So we do planning for people who are looking at needing long-term care and knowing their own assets or resources are not going to get them there, right, for as long as they need. So there are strategies, including giving away some assets in order to qualify for Medicaid. There is a 5-year look back. So any giving away of things done for a purpose of qualifying for Medicaid has to be done 5 years before you need the Medicaid, before you need to qualify.
But again, the reason that most people run into is Medicare won't take your house. You can live in your house until you die. That's when they then try to take that asset from you and reimburse themselves for their expense for your care.
So that is sort of true. When a person applies for Medicaid, there are exempt assets, and a car and a house are exempt assets. So if a person needs Medicaid, they may live at home and it's not counted against them. If the person has to leave the home and go to the nursing home, then that home is allowed to be owned for a year. And then Medicaid will put a lien on it, not take it away from you. There are, at the very end of this, we talk about a caregiver exception, a child caregiver exception. If a child moves into a person who needs Medicaid's care and cares for them for 2 years, the person is allowed to give the home to the child, and it's not a prohibited transfer, so there's no penalty. The eligibility for Medicaid works. but there's evidence that you have to support, provide in supporting that exemption when you apply. Also, what was I going to say? There, as an alternative to the idea that Medicaid will take the home to pay themselves back, they'll put a lien at the death. They'll take the value of the services that Medicaid's provided from the property. If the property value exceeds that, then the heirs can keep it. And then what really happens in practical terms is that there's a delay in qualification. It's not, they call it a penalty period. So
Right.
Medicaid will take the value of the excess resource, the home in this example, do some crazy calculation that I cannot describe for you, and come up with a period of time that you will not be eligible to receive Medicaid benefits. During that time, however, there's creative solutions to get the care that's needed paid for. And some of those solutions are called a Medicaid spend down. You can sell the home and then you've got a big pile of money and you can spend it in certain ways that Medicaid overlooks, and still be qualified. So that's what I mean by planning is always better. We can do that planning in a crisis. If we know you're looking at a need for long-term care and you know you don't have a pot of money that will pay for it as long as you need it, we can get together in advance and apply some of the strategies. An irrevocable trust, a Medicaid payback trust, an Medicaid income trust are all choices that we can put together. You can spend down excess resources like we talked about in ways that will still benefit you with your stuff, but not disqualify you from Medicaid.
Right. So when we're talking trusts, that's why those others, like MIT or Miller Trust.
Yeah, Miller Trust is an income trust, that's right. So there are strategies that we can employ. Some of them are distasteful, so you want to try to do it closer in time to when you need the care, because mostly people have worked really hard to get their resources and their assets, and just giving them away feels bad. So let's get away. The last will we talked about, that's the document where you make your wishes known. It takes a judge to effectuate those wishes. A will is available on the internet, friends. I mean, just about anything is available on the internet. Using a lawyer to do a will enables you to figure out if there are other things that can work in conjunction with that will that helps you. It can allow you to do some strategic things. So it may be worth just talking to a lawyer about whether you need one or whether you should just get a plain vanilla one. Let's keep going. Estate tax planning, we kind of talked about. The estate tax exemption amount that I talked about is set to change in 2025. So if you're if you're somewhere between 3 to 5 million in your estate and that 12.9 million, you may want to give some thought to estate tax planning, because I don't know what will happen in 2025. The amount in the statute is 3 million, but it's probably going to be higher than that, but I don't know. Non-testamentary transfer of property, you can do that. We talked about that transfer on death deed. We talked about joint ownership. The problem with the transfer on death deed is if your beneficiary in that document dies before you, people die in the wrong order, you're stuck with that property still in your estate. So something to think about. Don't forget the batteries. This is in doing an estate plan, if you write a trust, if you don't put your assets into the trust, they're still in your estate and you could wind up going through probate because this asset hasn't been put into the trust. So in addition to putting your property into your trust, you need to coordinate life insurance beneficiary designations, retirement asset beneficiary designations, and you might want to do some pay on death designation on your accounts. The pay on death stuff, though, requires everybody to die in the right order. So it should be used in conjunction with other plans as well. Yeah, review often. So if no planning, then what? If you become incapacitated and you haven't appointed an attorney in fact to make healthcare and or financial decisions for you, then your loved ones are going to guardianship court and they're proving to a judge that you're incapacitated. They can do that by With medical diagnosis, there's a requirement to provide a letter from a doctor that's less than 60 days old to establish the need for the guardianship. The Oklahoma Guardianship and Conservatorship Act is in the statutes, and a guardian will be appointed. Those guardians then have, under Oklahoma law, the highest duty to act in the best interest of the ward. So the guardian is the caregiver, the ward is the one who needs the protection. And it requires court oversight. So you have to get court permission to do things like make an estate plan for a ward. You have to get court permission for a ward to get married or divorced. You have to get court permission to sell a ward's property. And then there's annual report requirement. Guardians have to give an annual report about the person and the property of the ward. So all of that can be avoided if there is an attorney in fact appointed. So it just depends. And I'm involved in a lot of guardianships where APS, Adult Protective Services, have been called by a bank who says, somebody's withdrawing a bunch of stuff out of this person's account. Stephanie, help me stop that. And I have to go to guardianship court, and I have to find someone willing to be the guardian. Oklahoma does not have an office of public guardian like California does. So if someone doesn't have a loved one, a family member, or a friend who's willing to step up and act for them, I have a really hard time finding people who, lawyers will do it, but it's expensive. There's there's one company in town that will serve as guardians of people, and they're expensive too. So that's why I say making a plan is the best. Medicaid planning, if you don't plan ahead for ownership of your assets, then we may scramble when Medicaid is needed to preserve as much of your estate as we can. Eligibility for Medicaid is established for a medical reason and a financial qualification. You can have no more than $2,000 a month in income and no more than $2,000 worth of resources. Resources, to me, I call them assets. That's your 401k, that's your savings account. It can be, cash value in a life insurance policy, stuff like that counts here. We talked about that a little bit earlier. Your home and your car and the contents are generally speaking exempt. So no one's going to be counting the silver spoons to figure out if you hit that $2,000 resource limit, but a Monet collection will, that counts. Gold bars and stuff count. So we talked about the child caregiver exemption. That will allow a Medicaid applicant to transfer their home to a child who's been living with them and providing care for 2 years. There's another exemption that I didn't put on here, and that is a Medicaid applicant can give away resources to another disabled person, and that transfer counts. So if there are multiple family members and you're trying to do estate planning for someone who's in a critical circumstance and needs Medicaid, that's a choice. So I kind of went jumbled and I kind of went fast, but that's all that I came prepared to talk about, and I'm happy to stay and answer questions if anybody has them, and I hope it was clear and helpful. These guys gave much more sort of practical knowledge, but if you have time, planning's a great idea.
Amen.
Thank you. Yeah, thank you guys for letting me talk.
Thank all of you.
Thank you for all of our speakers today. It's been incredible. I think we could be here 4 or 5 hours and just listen to all this knowledge. So, thank you all for coming. If you wouldn't mind filling out your evaluations that are on the table, we'd appreciate that. And you're welcome to take all the handouts. Go ahead.
One thing, if you guys found this useful, and I hope you did, I thought it was fantastic. Thank you to all the panelists. Great. We're going to do this probably again, early fall, I would imagine. So tell people in the church, I mean, there's no need that we should have 50 to 100 people at these things. We really should.
I think I've always been under the impression though, that it was maybe Only if, I mean, since the information given today was applicable even if I'm not a caregiver.
Absolutely.
And so I think I was under that impression too, so I think. Yes.
Any suggestions you guys have, that'd be awesome. Thank you.
Yeah, you're right. Caregiver group with Martha, and I have for several years.
I think any of us could talk
The
for a couple
information
hours.
I've gotten from her, I've been able to share with the caregivers through the VA. So it's all great information, whether you're a caregiver or you, and as we get older, you're gonna have people you gotta care for.
Well, even like the trust stuff, I mean, if you're not even a caregiver, I'm a big fan, you need a trust.
Well,
You really do.
Medicare stuff is important too, as far as I understand.
It's super hard. And it goes back and forth.
Yeah.
And I always tell people, even if you're not a caregiver, you probably know someone who's a caregiver, or you might become a caregiver, so all of these, it's a very broad term.
You're getting groceries
I needed you a week ago.
I'm serious. You're late.
I'm late. $28 for the how I live, so.
Catapulted into, my mom's still living in the home. I find out it's long-term care.
Okay.
So just ask that.